Now let's go to the next session with Dr. Mu'taz Qaderi, consultant electrophysiologist in Med Clinic. Floor is yours, Dr. Mu'taz.
Thank you very much for the organizers for the kind invitation. So I'm going to talk to you about how I would approach patients with PVCs. I get a lot of patients with PVCs being referred to me to the clinic, and I'll take you through my lines of thought when I deal with these patients. So PVCs are quite common. We see them roughly in about 1 to 2% on just 12 lead ECGs. Probably about 70% of the patients who have Holter monitors will have a degree of PVCs to varying levels. In general, they tend to increase with age, although we see quite a lot in younger people. And they also increase in patients who have structural heart disease. So in terms of investigations, when we see those patients, the first thing is to try and get a 12-lead ECG on these patients. And what I mean by 12-lead ECG is that I need to really see the ECG in all 12 leads. Okay, so if you have a 12-lead ECG and it shows it only in V1, V2, V3, that's not enough for me to localize it. I need to see the PVC. So you might have to do a longer rhythm strip or get 2 ECGs. As long as I can see them in the 12 leads, I can localize it more. And then the ECG will also help you to see if the patient has got any other problems like, previous ischemic heart disease or anything like that. Then you get a Holter monitor, and the important bits in a Holter monitor is to look into the PVC burden. So how much PVCs is this patient, having? And it's not the absolute number, it's the percentage. So sometimes patients tell, well, this patient's got 10,000 PVCs, but that's a 7-day Holter. So on a 7-day Holter, 10,000 PVCs is like 2% or 1%, and that's a small percentage. What number of different morphologies? So the success rate of our procedure is related to the number of morphologies. So if you have somebody with monomorphic PVCs, it's a single focus. You go and ablate it, you get rid of it. If they've got multiple morphologies, it's like doing 3 different ablations on this patient. And then you also look into diurnal variation. So is it more during the night? Is it more during the day? So if it is more during the night, for example, I might need to sedate this patient more during the ablation procedure to be able to get those PVCs to increase and so on. You'll do an echocardiogram, and that will be to assess the ejection fraction, see if the PVCs are affecting that, and also to look into an underlying cause. So has this patient had a previous myocardial infarction, which could be the edges of that scar, could be the source of these PVCs. You'll get a cardiac MRI. I don't tend to get a cardiac MRI on straightforward cases like outflow tract PVCs, but if they're coming from a location which is not very classical, then I'll get an MRI just to make sure that there's no underlying cardiomyopathy causing this. You can do a stress test, and some people look into whether it's being suppressed by the exercise or whether it's being induced by the exercise, and if there are any signs of ischemia as well. In some cases, you might need to do an angiogram. Classically, PVCs are not caused by ischemia. It's caused by scar or they're just idiopathic. So an angiogram is not a common thing unless you clearly identify that the patient has ischemia substrate to it. So when I see one of those patients, there's 6 things that go into my mind, and that helps me to decide what I do with this patient, okay? So I have a PVC, and I need to come up with a management plan. So first thing is I would look into, is this PVC dangerous? Is this patient going to die because of this PVC? Is it going to cause sudden death in his case? Does this patient have any symptoms? Is it affecting their ejection fraction? What's the PVC burden? And how easy is it for me to get rid of this? And then what does the patient want? And often the decision at the end is going to be a combination or, various degrees of one of these elements or all of them. So let's go through them. So the prognosis of risk, in the vast majority of patients, PVCs are not a direct risk to death or leading to death. So they're not direct risk to life. But you have to worry about certain patients. So if somebody has a family history of sudden cardiac death, you have to worry about these patients. Patients with structural heart disease, these tend to have more sudden death with their PVCs. If the patient's already had syncope, particularly if the syncope sounds arrhythmogenic in nature, and shortly coupled or uncoupled PVCs, okay? So if you get PVCs that are falling on the T waves, you worry about these ones. So here's a trace from a patient who the PVC is falling right on the T wave. Now she had only 100 PVCs, but the complicating factor in her case was that she also was known to have Brugada syndrome. And this is a case that we discussed a lot within our EP group to decide what to do with her. And we end up doing a diagnostic EP study with 3 extra beads, and we couldn't induce anything, so we were quite happy with it. Second thing is symptoms. Symptoms are very subjective. Patients with PVCs can come up with all sorts of symptoms. So the classical one is they tell you, I get thumping beats in my chest, fine, but some of them complain of shortness of breath, of fatigue, low blood pressure, just generally feeling unwell, and so on. I always tend to have a short trial of medical therapy, suppress the PVCs, and see if the symptoms have disappeared. Because if they do, then that confirms that the PVCs are the cause of these symptoms that the patient was complaining of when they came to see you. The third factor is ejection fraction. So PVCs can cause heart failure, so that's called PVC-induced cardiomyopathy. But equally, PVCs are common in patients who already have heart failure. So in about almost 70–80% of the patients who have heart failure, they tend to have PVCs as well. So again, it's a chicken and egg situation. You don't know which one is causing the other one. And in patients who already have impaired LV function, the PVCs can worsen the heart failure even further. So what factors are associated with PVC-induced cardiomyopathy? So the PVC burden, the higher the PVC burden, the more likely you are going to have PVC-induced cardiomyopathy. And the classical number mentioned in the literature is 15 to 20% or higher. So things like less than 10%, it's unlikely that it will cause any major issues in terms of drop in the ejection fraction. Longer duration, so if you've had it for many years, it's likely to cause it. Patients who are asymptomatic, because these people don't go to see the doctor, so they're found out many years down the line. Epicardial VTs, so the PVCs which have very, very wide QRS. Interpolated PVCs, and males tend to have more PVC-induced cardiomyopathy. And the data is very clear. So this is the data from Michigan where I did my training. So patients who had ejection fraction of about 35%, you get rid of the PVCs, the ejection fraction goes back to normal. And even patients who already have established scar, who already had established cardiomyopathy, the patients who had successful PVC ablation, their ejection fraction improved versus the ones who had unsuccessful PVC, their ejection fraction in general didn't improve. So if you have somebody who has established heart failure and have PVCs, a lot of the times if you get rid of the PVCs, their ejection fraction would improve. It may not go back to normal, but it might go up by 10% or something like that, which can be the limit between multiple admissions with heart failure and being completely symptom-free. PVC burden, the higher the burden, the higher the chances that you will have PVC-induced cardiomyopathy, the higher the chances of symptoms, and probably the higher chances of having more sustained arrhythmia if they can start sort of organize themselves into non-sustained VT and so on. Normally, you need at least 15 to 20% for it to start affecting the ejection fraction, as we said, and anything less than 10% is unlikely to affect the ejection fraction, and can be very variable, and particularly in females. So we have seen females that, around the time of pregnancy or near the period time, they'll have a flare-up of their PVCs and it would settle down after that. Ease of ablation. So in general, the location of the PVCs, so outflow tract PVCs, fascicular PVCs, tend to be easy to get rid of, and you can give the patients very high percentage of success. The lower the PVC burden, the more difficult they are to get, because for me to be able to ablate them, I need to make my map while I'm seeing the PVCs. So the higher the number of points that I'm taking, the more accurate my map is. Like any picture, the higher number of pixels, you're going to get a more clearer picture. So if you have a patient who gets 1 PVC every 2 minutes, I'm going to be able to create a map with only like 50 points, and that's not going to be that accurate. Whereas if somebody is in Gemini, I'll be able to take lots of points in about 10–15 minutes, have a 400-point map, and that would be more accurate. Patients' age, I don't deny patients treatment per se because of age, but you have to be careful that higher age, they tend to have more comorbidities and the risk is slightly higher. And that's what I've just mentioned. Patient's preference, so do these patients want to be on long-term medications? Do they want to be followed up on a regular basis, having ECG and Holter and echo every few months? Occupational requirements, for example, ADNOC would not allow patients to go offshore if they have PVCs. Pilots, it's a no-no for them to be on flecainide or sotalol, and so on. Fear of the procedure is a very common thing in the Middle East. Patients in the Middle East don't like procedures. They don't like to take medications, they don't like the procedure, but they still would like to get rid of the PVCs. So you have to sit and explain to them about these procedures, trying to convince them about it. So what are the outcomes? So the outcomes are not very good if you don't do anything, or if you use classical antiarrhythmic agents like beta blockers and calcium channel blockers, and slightly better if you use flecainide or sotalol, but nothing is really very good result there. Success rate with ablations, so it's a bit of a busy slide. So if you look at the blue line on the top, that's success rate for RVOT PVC ablations, so above 95% acute, and similar if you need to use some medications in the longer term. Cusp PVCs tend to be a bit less than 90% as acute success rate. Papillary muscles about 70%, epicardial about 70%. If you have multiple morphologies, it tends to be relatively low. Whereas if you have a single PVC morphology, it tends to be higher. Now, in terms of complications, you can see that about half of the complications are due to vascular access, and in this day and age, I think vascular access should not be an issue because we should be using ultrasound for our access. So in the last 10 years, I've had only one fistula, and in doing almost more than 1,500 ablations. So it's become significantly safer in that respect. And even the catheters themselves, now we get contact force feedback from the catheters. So the risk associated with these PVCs now has become exceedingly small. Not zero, but very, very small. Here's a little meta-analysis that compared studies comparing antiarrhythmic agents with catheter ablation. So catheter ablation was associated with lower PVC recurrence, lower PVC burden, and higher ejection fraction. And the complication rates ranged between 0% and 5%, depending on the study. But antiarrhythmic agents were not much better. They had a much higher risk of side effects and complications with them. So what do the guidelines recommend? So if you have somebody who has PVCs, you get an ECG, Holter, and an echo on them, and then you get an assessment. So if there's something not sounding right, you probably should get a cardiac MRI. So if the PVCs don't look like they're coming from a classical outflow location, you should get an MRI on these patients. But if they have a structurally normal heart and you think they have idiopathic PVCs, the next question, do they have symptoms? If they have symptoms and it is RVOT, then catheter ablation is your first choice. And second choice would be medications. If they're non-RVOT, then medications are probably slightly better because the ablation is not going to be as easy, and then catheter ablation would be a second choice. If they're not symptomatic and the PVC burden is above 20%, you need regular follow-up on them. If the burden is between 10 and 20, regular follow-up. If the burden is less than 10%, is you discharge them. If they have structural heart disease, then we go for the next side, which is this one. So the right side will be tell you if you have already LV dysfunction in these patients, but you can explain the impaired LV function by the underlying condition itself, then you can probably just observe them. But if you feel that the structural heart disease is being aggravated by the PVCs, then catheter ablation is your choice. For the patients who are suspected to have other comorbidities, you need to investigate them further. If the cardiac MRI shows LGE, if the MRI does not show LGE, then it's probably PVC-induced cardiomyopathy, and catheter ablation is the first choice in these patients. So just to summarize, RVOT PVCs, if they're symptomatic, you do ablations at your first choice. If they are other than RVOT, then maybe medications might be slightly better. If you have LV dysfunction, whether RVOT or not, catheter ablation is a first choice, and you have other medications that you can try. If the PVC burden is above 20% and they're asymptomatic, the guidelines would say you either go for ablation, which is a class 2B, or you actually don't do anything. So factors to consider, out of all of those, I think the most important are ejection fraction and symptoms. So in terms of practical points, obtain a Holter monitor, tell me if they're monomorphic or not, tell me what the PVC burden on them. Please try to get me a 12-lead ECG so I can localize them and tell the patient where they're exactly coming from and give them realistic numbers in terms of the success rate. If the PVC burden is above 10%, we tend to try and suppress them in this country, maybe slightly against what the guidelines would say. You can start a beta blocker, but you can also try a class 1 or a class 3 agent. You can consider catheter ablation if you have a young patient, if the medication is not working, and particularly if it's like a low-hanging fruit, if it's like a very easy location that you can get to and you could have a very high success rate. So for our VOT ablations, I would say it's a 95% success rate that I can get rid of it for them. 70% for papillary muscles, or if they're epicardial or they have multiple morphologies. So in summary, PVCs plus symptoms you should treat. If they're outflow tract PVCs, ablation. If they're atypical locations, maybe start with medications. PVC and low ejection fraction, treatment, and preferably ablation. PVCs and no symptoms and normal ejection fraction, observation, but you can also offer them ablation, and that depends on the patient preference, the burden, and the ease of ablation itself. If you're going to do observation, you're going to need to do an annual echo, Holter, and ECG on these patients. Thank you very much.
Mu'taz, for your presentation. Any questions?
Good, thank you very much.
I think Dr. Mu'taz, regarding patients with burden around 10% and they are refusing to go for the ablation, this is the only solution to go for flecainide or cordarone?
It depends on symptoms and ejection fraction. So if they don't have symptoms and their ejection fraction is normal, they don't want to do anything, that's perfectly fine with me. Okay? If they have symptoms or their ejection fraction is low, then I tell them, look, we really need to suppress those PVCs. And you have the option, you either take medications or you go for ablation. But for them to tell you, I don't want to have the symptoms and I don't want to take medication, I don't want to do the ablation, there's no way for me to get rid of these PVCs for them.
Like most of us, yeah. Thank you, Dr. Mu'taz.
Thank you.
Now let's go with the next presentation with Dr. Rami Harb about non-ischemic cardiomyopathy evaluation. Floor is yours. And Dr. Bashair, sorry.
Thank you, Dr. Abdul Mana, for so can we have the presentation, please? Fine. Thank you again for the opportunity to present. We'll be presenting non-ischemic cardiomyopathy. We'll be focusing mainly on the diagnostic aspects, the prevention of sudden cardiac death, and definitely the symptoms. Treatment, mainly EP treatment, is discussed with Dr. Mu'taz and Dr. Sabur later on. And surgical treatment were discussed as well, I think, with Dr. Walid before. So we have no disclosures. I'll go through this slide, which summarizes a little bit what we're gonna talk today. So the key aspects in the evaluation and management of cardiomyopathies, we usually depend on detecting the symptoms, knowing the symptoms, what are the symptoms of the patients, what are the findings, whether incidental or not, and which diagnostic techniques we'll be using. In here, we're gonna focus on the highlighted items with arrows on HCM, DCM, and ARVC, which are very common, more common than the other cardiomyopathies. The diagnostic, as I said, workflow will depend on the symptoms and findings. And as we see that a lot of cardiomyopathies or lots of cardiomyopathies do overlap, as Dr. Bashar will be talking later on, like the overlap between HCM, burned out HCM leading to DCM, or DCM, ARVC, or other findings. So I'll start with hypertrophic cardiomyopathy. I'm gonna be a bit, as I said, we'll not talk about treatment, it's mainly diagnostics. So hypertrophic cardiomyopathy is mainly an autosomal dominant disorder characterized by unexplained LV hypertrophy, myocyte disarray, unexplained by loading pathologies, myocyte disarray and fibrosis. It's the most common inherited or heritable cardiovascular disorder with a prevalence of 1 in 500. Usually, it's a disease of the sarcomere with more than 400 mutations in the 11 different components of the contractile apparatus. Men are equally affected as women, prevalence in different racial groups is similar. It's very important to detect this because it may lead to sudden cardiac death or heart failure or sudden cardiac death, especially in young athletes and young people. So, what's wrong? What's wrong? Fourth slide, please. Sorry, please. Can you fix the slides? I'm not able to advance it from here. Okay, fine. Okay, so the scheme on the left will depict what we're talking in a normal endomyocardial biopsy for a normal patient with a normal human with no cardiomyopathy or no hypertrophic cardiomyopathy. The scheme on the right will depict what we mean by the myositis array, which is a non-parallel distribution of the cardiomyocytes along with fibrosis distributed throughout the myocardium, which will be the niche to have arrhythmias. So the diverse etiologies, we have, as we said, genetic and non-genetic. Among the genetic, we have the sarcomeric, which are the most prominent. Between 40-60% sarcomeric protein, sarcomeric proteins, gene mutations, I mean. We have the most prominent are, is the cursor? Yeah. The myosin binding protein C mutation and beta myosin heavy chain, accounting for 35% each. And the others are like troponin and tropomyosin mutations. The other mutations as well, we have the AMP kinase, we have the lysosomal storage, mitochondrial, as you see on the left side of on the right side of the slide, along with the non-genetic causes like inflammation, endocrine disorders. So this is what we're talking about. That's mainly the myosin binding protein C. It's accounts for like 35%, and the other one is a beta myosin heavy chain, 35%. Those could be more prominent, however, not that as aggressive as other mutations, as we're going to talk later on. So the symptoms range from shortness of breath, angina, palpitations, collapse, and aborted sudden death, of course. And the diagnosis is mainly made if we find a patient with more than 15 millimeters thickness in one or more LV myocardial segments, unexplained solely by loading conditions. Sometimes we can find a lower incidence, a lower thickness, however, having provocable gradients, for example, and we rely mainly on the family history. The family history is very important, the ECG, the other diagnostic modalities that we're going to talk about. So diagnostic modalities, again, very quick. ECG, echo, we depend on the echo too much, on the prolonged Holter monitoring, on the cardiac MRI, on the contrast echocardiography, TE, the nuclear, the CPET, along with some invasive pressure studies. I'll pass now to Dr. Bashair. You can pass.
Yes. Hello, so we're the first duo presenting, and I think that just summarizes how complex these heterogeneous cases are, and oftentimes we rely heavily on imaging for diagnosis. So I'm going to focus on cardiac MRI and echo, and we pit them against each other a lot, but in reality, they should both be performed. I think the power horse, of course, is always echo. It's widely available, it's cheap, all of our patients get it first. But oftentimes, echo is better for hemodynamic studies and quantification of gradients at rest and stress, which is where I think it shines mostly. But cardiac MRI has better spatial resolution and has a more precise assessment of LV wall thickness. and has better characterization of complex phenotypes like patients with apical hypertrophic cardiomyopathy. But where it really sets itself apart is tissue characterization. As we know, it's the only modality where we can do T1 mapping to quantify myocardial tissue and late gadolinium enhancement to assess for scar. So as Dr. Rami nicely summarized, this is a heterogeneous group of diseases and with different morphologies. On the left-hand side, you see the sigmoid hypertrophic cardiomyopathy, which is the most common form that we encounter in clinical practice, but unfortunately only 10% of those are myofilament gene positive, which can make diagnosis sometimes difficult, especially early on in the disease course. And as you can see, the reverse curve hypertrophic cardiomyopathy is the second most common, but 80% of those cases will come back with myofilament gene positive. And this is not just semantics. A lot of the time, this will dictate disease course. In patients with reverse curve hypertrophic cardiomyopathy, because of the curvature of the septum, those patients tend to get LVOT obstruction more. So those will be hypertrophic obstructive cardiomyopathy as opposed to the other morphological variants that you see on the slide. And I'm going to shift gears to hypertrophic cardiomyopathy advancing into LV dysfunction because MRI has excellent spatial resolution and better volume measurements. We can get accurate assessment of ejection fraction. And although the prevalence is low at about 8% of all comers with hypertrophic cardiomyopathy, this really it also delineates the risk factors that we see, and we can predict patients who may develop systolic dysfunction, like patients with thin filament variants like troponin T, troponin I, as well as patients who've had septal reduction therapy, increased LV thickness. And as you can see from the slide, these patients tend to have a poor prognosis with a median time of 8 years. 75% would have experienced an adverse event, 35% rate of death, transplant, or LVAD, and predictors of prognosis alongside with a reduced LV ejection fraction is also development of atrial fibrillation or patients who have multiple sarcomeric pathologic variants on genetic testing. Cardiac MRI will also help identify patients with aneurysm formation. This is oftentimes missed on echo, especially if contrast was not used during echocardiography. And this is about 5% of patients with hypertrophic cardiomyopathy. It occurs in mid-cavitary obstruction or apical hypertrophic cardiomyopathy. And patients with this variant tend to have a higher risk of sudden death, irrespective of other findings that we see on MRI, and increased thromboembolism at about 1% per year. And this is just a nice schematic of one of our still images for late gadolinium enhancement in a patient with concomitant apical septal variant hypertrophic cardiomyopathy, but also ischemic heart disease, as you can see from the subendocardial LGE. But you can also see nicely that this thrombus was caught on LGE images, which is another perk of cardiac MRI. And another thing that cardiac MRI really helps us classify is the mitral valve abnormalities that we do see with this disease. Commonly, this is anterior leaflet elongation, but we can also measure the posterior leaflet and evaluate abnormalities of the papillary muscles much better than we do with echocardiography, such as how many papillary muscles are there. You can also see a more apical insertion for papillary muscles in different distribution. And this is just another nice schematic of late gadolinium enhancement. As we know, this is one of the most important things that we identify on cardiac MRI in these patients to stratify their sudden cardiac death risk. And this is a slide just to illustrate that the amount of LGE is a risk factor, and with patients who have more than 15% of their LV mass demonstrating LGE, demonstrate a twofold increase in sudden cardiac death. So quantification of LGE is extremely important, although in clinical practice, it is challenging, especially if patients get their MRI in different centers, different cardiac MR scanners, and different operators or interpreters. And I'll hand it over to Dr. Ram.
Thanks, Dr. Bashar. Thank you for your CMI extensive experience. We'll continue on the diagnostic and investigation route. So genetic testing, family screening is very essential in this cohort of patients, especially that when HCM cannot be explained by non-genetic causes. So as we said, it's a disease of the sarcomere with different protein genes being involved. So sequencing of sarcomeric protein genes is essential. It's present. It's a disease causing in up to 60%, as I've mentioned in one of my previous slides. Other modes of transmission could be autosomal dominant in 50%, de novo mutations, less commonly autosomal recessive. Sporadic cases can be caused by incomplete penetrance. We can explain that if anyone has a question at the end of our lecture. And genetic analysis, the most important and diagnostic remains genetic analysis on post-mortem or DNA samples can be valuable. Sometimes we may find in screening lots of non-synonymous genetic variants of unknown significance, and that will take us into a dungeon it will make us lose our way while making the diagnosis. I will mention, though this slide is involved in the management treatment, but I have to go through it quickly, please. Patients with a provocable gradient or resting gradient 50 or more should be considered for LVOT treatment, which may be very beneficial for the patient. So even if we're suspecting that the gradient is lower than 30, we can do like stress echo and try to provoke the gradient, or with Valsalva, and we'll go through LVOT management like septal reduction and stuff like that. This is the second thing other than diagnostic we're going to talk about is the risk of sudden cardiac death. This is the old protocol that was used by Barham McKenna before, and it's the risk of sudden cardiac death. So we have to have 2 out of 5 risks in order to commit patient for ICD implantation or not. So mainly inappropriate blood pressure response to exercise, non-sustained VT, wall thickness of more than 30, unexplained syncope or family history of sudden cardiac death. Some people who included as well the LA size, because it will talk about the LV and diastolic thickness and diastolic volume and the thickness of the LV. However, in 2014, we came out with a new calculator, Mahoney and et al. In Bart's. They came with this calculator, taking into consideration other risk factors like in addition to the LV wall thickness, they include the LA size. They remove the blood pressure blunting or flattishness on exercise, and they came out with this calculator. So anything less than 4% in the calculator will classify the patient as low risk and not needing an ICD. More than 6% will need an ICD, and in between the two will go independently, and we'll keep reviewing the patient. Regardless, patients, as Dr. Mu'taz has said, like the same protocol of PVCs, they should be assessed yearly. These patients should be assessed sometimes more than yearly. Like twice a year, with revision of the calculator on every presentation and see whether we should advance for ICD implantation or not. I'll go for the second topic, which is the dilated cardiomyopathy. Is going to be quick. So the causative factor, I'm going to focus, my objectives are to focus on as I said, on the causative factors and the diagnostic workup. So mainly there are 2 main categories, is familial and non-familial, which is not genetic. What we mean by dilated cardiomyopathy is the LV dilatation by LV EDD of 2 Z-scores above the population mean for age, for size, gender, and or age. EDD more than 58 in males, more than 52 in females, or LV-EDV of more than 75 in males and 62 in females, in addition to LV global dysfunction of less than 50%. So the prevalence of DCM is like 36 per 100,000. Annual incidence is around like up to 8% per 8 per 100,000. It remains the major cause of sudden death in young adults, and is currently a most frequent diagnosis in patients referred for heart transplantation. And the course of the disease is unpredictable. So some patients may be asymptomatic and presentation, then they develop disease quickly. So it is severe rapid progression to progressing to death, and typically prognosis poor with a 5-year mortality rate of up to 46%. So the etiology is heterogeneous. So DCM is common for numerous heart conditions, and that's why the etiology is frequently difficult to identify. We have mainly 3 main categories, which is the inflammatory, the inherited, and the idiopathic, which they divide equally the percentages, like 30-35% each. Other causes of DCM remain the other type of cardiomyopathy. Cardiomyopathies, for example, like hypertrophic cardiomyopathy, burning out and developing into DCM, connective tissue diseases, endocrine disorders, infiltrative, medications and toxins, tachycardia-induced or ectopic-induced, as Dr. Mu'tazza mentioned before, and other miscellaneous causes. The familial is considered, cardiomyopathy is considered dilated familial when more than one first-degree relative has been diagnosed. It can be diagnosed in between 20 up to 50% of patients with initial diagnosis of idiopathic. And the true frequency is not clear, to be honest with you, because some patients at first presentation may be normal, but however, with the rapid progression of the disease, they may be diagnosed later on to have the pathology. So, as I said, the percentage 90% between the 3 main categories. So 35% of the dilated cardiomyopathy are noted to be genetic. So transmission is autosomal dominant, autosomal recessive, X-linked, and mitochondrial. It's a monogenetic disease. However, it can be polygenetic, increasing the risk if there is polygenes. Mainly 30 genes are identified. Different than having sarcomeric proteins being involved, like in hypertrophic cardiomyopathy and DCM, we have sarcomeric, of course, but we have the nuclear envelope involvement, we have the ion channels, transcription factors, and different dystrophin-associated cytoskeletal complex. So it's a different involvement other than the cardiac sarcomere. The main genes that increase the risk of sudden death in these patients are the lamin AC mutation, the filamin, and the plakophilin, the desmoplakin. Lots of these are mainly 6 of the most important genes that, if found in inherited genetic cardiomyopathy, they increase the risk of sudden cardiac death. So after all, it's a gene that is present. So different people having different genes may have different phenotypes according to the environmental factors that they are exposed to. So some people may be asymptomatic while having their genes, whereas others, while having different environmental factors, they will be prone to show the disease, like if they're exposed to viral illnesses and stuff like that. So the non-familial, I'll go quickly through that. The inflammatory dilated, that's mainly caused by viral illnesses, less likely by bacteria and protozoal agents, and it develops, as I said before in the previous slide, in susceptible individuals. So other cardiomyopathies like end-stage HCM developing, RCM, all of them developing with DCM, into dilated, the connective tissue, endocrinologic, toxins, medication-induced, and tachycardia-induced, with infiltrative diseases being as well taking part. Sometimes in neuromuscular diseases, we find patients having dilated cardiomyopathy, like in Duchenne and Friedreich's ataxia with myotonic dystrophy, neoplastic diseases, neoplastic heart disease, celiac, extensive chest radiation, obstructive sleep apnea, and so on. So it is a matter of how to prevent the patients from progressing into a risk of sudden cardiac death. So if patients presented with cardiac arrest and VT, VF, they should have aborted VF. They should progress directly into it's a class 1 indication to have an ICD implanted. If not, we'll look at the LVEF. It is low, less than 35%. I think Dr. Mu'tazza will agree on that. It's class 2A. Will implant an ICD, or high-risk genes, as I mentioned before, there are 6 genes. having, going to this scheme, their class 2B to have an ICD implanted. The last pathology I'm going to talk about, sorry for being quick, but I hope that, that it is informative, is the ARVC. So ARVC, this is what we're talking about. It's fibrofatty replacement of the heart muscle. So we see the, we see the fatty streaks and fibers. So it is a disease mainly of the gap junctions, the desmosomes, and the fascia adherens. And so it's an inherited disease characterized by fibrofatty replacement, as I said, of the myocardium. The prevalence ranges from 1 in 1,000 to 1 in 5,000 individuals, male predominance among probants. Usually patients that present with VF at first presentation are typically younger patients than those compared with presenting with monofocal ventricular tachycardia, which may present at an older, with a mean age group of 36 years. So it is, as I said, it's a mutation, mutation of the desmosomal genes, of the genes coding for desmosomes. I mean, it's, we have to make the diagnosis by genetic testing as well, confirm the diagnosis by genetic testing, but there is a task force criteria that I'm going to talk about. People that have more than one gene involved are at a higher risk of ventricular arrhythmia and death. So I'll skip this one. So ARVC is characterized mainly by RV involvement, though LV involvement may be present there, like LV, LGE. Dr. Bashar will talk about that in a bit. The percentage usually, it's frequently observed, and the percentage 29 to 53% for RV fatty infiltration and 36 to 45% of LV, LGE in probands. So even the probands may present with this genetic variation, even if they didn't develop symptoms, even before they before having symptoms. So we can find this. So the identification can be biventricular, and as I said, for the ARVC, thus we'll be expecting that they will change the name into arrhythmogenic cardiomyopathy after taking the approval of our EP colleagues. So these are the main genes involved. The plakophilin remains the most prominent in frequency, the desmoglein and the desmoplakin, with lots of, even lamin AC, which is common with dilated cardiomyopathy. But the first three are the most common in here. If we look at the ECG of someone that we're suspecting ARVC, we know that there is something called the epsilon wave, okay? So if epsilon wave is present, that will favor, and in the patient coming with syncope, having lots of ventricular ectopics, will be thinking that could be ARVC and send them for an MRI. One test that is done, and usually Dr. Mu'taz probably will comment on that later, is a signal average ECG. I'm pointing on you too much, Mu'taz, sorry. So it's a signal average ECG, and that is one of the minor criteria in the task force, as I'm going to see later on. I'll summarize it in a way so that you'll understand it. So the signal average ECG will depend on these three parameters. And for example, in this example, the three parameters are positive, so that is fulfilling the minor criteria for minor task force criteria. So this is LV involvement. In order to understand the RVC properly, we have to go to the task force criteria 2010, which is the new guideline. And that lists 6 main categories, like global RV involvement, minor, it's divided into major and minor, the tissue characterization, major and minor, what is the fibrofatty, how much involvement of the muscle is there, the repolarization abnormality, whether there are T-wave inversions anteriorly or minor and major as well. And this is the second one. So that depolarization, as I said, late potential, epsilon wave remains as a major criterion, whereas late potential is a minor criterion, and arrhythmias, how much ectopics we have, ventricular ectopics, and family history of sudden cardiac death, and whether we have a proband with genetic studies on postmortem. So any two major out of this table, or one major, two minor, or four minor will be a definite diagnosis of ARVC. So this is the most important pillar in diagnosing ARVC. I'll pass you now to Bashair.
Yes, so as Dr. Rami nicely pointed out, the diagnosis heavily relies on cardiac imaging in conjunction with clinical findings. There's, as you've noted, major criteria by echo and by MRI, and in this slide, I wanted to just highlight how much more your specificity increases, if you notice there, with the cardiac MRI, using the cardiac MRI major criteria, whereas sensitivity was much lower when you were looking at just diagnosis by echo. And you know, I know that you might say that I'm biased because of my specialty being cardiac MRI, but I wanted to just highlight a case of a patient of Dr. Rami's who has ARVC confirmed by genetic and imaging findings. And I'm displaying first the late gadolinium enhancement images in the short axis on the left side, 4-chamber on the right side, and you can nicely see the LGE, that's subendocardial, and the RV friole wall, which can sometimes be difficult to visualize because of how thin it is. And you can also visualize how dilated the RV looks. And this is a cine sequence SSFP of the same patient in 4-chamber view. And you can nicely see towards the distal portion of the free wall of the RV towards the apex, that dyskinetic motion and the bulging out during systole, which was actually missed on transthoracic echocardiography.
Thanks, Dr. Bashair. Again, we'll be finishing soon. We still have a few slides. So in the ARVC patients not implanted, we'll go, most important, as I said, is the risk stratification and knowing whether it should progress for ICD implantation or not. So in ARVC patients not implanted with ICDs, the risk of cardiac arrest may increase up to 6%, while 23% of patients experience non-sustained non-fatal, sustained monomorphic ventricular tachycardia. Among definite or probably RVC patients considered high risk, 23 to 48% will experience appropriate ICD shocks, 16% to 19% of which are ICD interrogation triggered by fast VT. I think Dr. Ahmed gave us a few more minutes, because he promised that, right? Yeah, okay. So the sudden death in young patients, as we see in here, ARVC accounts for like 30%, and among the different other pathologies include myocarditis, conductive tissue disease, and other pathologies. So the overlap syndrome, I'll pass it over again to Dr. Bashar before we go to our conclusions.
So as you've all experienced, I'm sure before, a lot of these patients in reality are overlap syndromes, or sometimes present really early in the disease course where it's very difficult to differentiate which disease entity they have. And this is just a nice schematic that summarizes the gray zone areas. A lot of the time, patients with ARVC may not present first with RV dilation. There might be LV changes first that might be close to non-compaction, or non-compaction cardiomyopathy with athletes' hearts. And what's nice about cardiac MRI is its excellent spatial resolution, and as well as the excellent contrast differentiation between blood pool and myocardium that helps us really measure these volumes, index them to patient body surface area, and helps us distinguish how close this is to either disease entity, or oftentimes how often do we need to continue imaging these patients before they develop a certain disease entity. Another part of the overlap syndromes, and I think where cardiac MRI shines again, is the role of T1 mapping, which is tissue differentiation. This really helps us find if there is evidence of fibrosis, as you can see from the schematic with the native T1 values on the y-axis and ECV on the x-axis. A lot of the time, this value does show us the different disease entities on the spectrum and helps us hone in our diagnosis. And I don't want to belabor this point. I think from Dr. Mu'taz's point all the way to Dr. Rami, we know that LGE is very good for prognostication, but it also really helps us determine disease entities depending on the distribution of these portions of scarring within the myocardium.
We'll come to the conclusion. So most people with HCM lead normal life without them having any symptoms. However, some other percentage, though smaller number, have difficult and critical symptoms. So diagnosis has to be founded on a concrete basis. And the most important thing, as we know in hypertrophic cardiomyopathy, is avoiding the arrhythmias. So Dr. Mu'taz will be happy. However, we have to treat the LVOT obstruction in order to avoid the occurrence of any symptoms. So the risk factors should always be reviewed on every presentation, as I said, and should go through the calculator, as I said before. We'll be relying more on the genetic testing and on the new diagnostic strategies. As to the DCM, as I said, it is summarizing different etiologies, genetic or non-genetic, mainly non-genetic, inflammatory or idiopathic, with the other like three slides that I presented will cause it etiologies of dilated cardiomyopathy. The treatment of dilated cardiomyopathy is treatment of heart failure and avoiding the occurrence of arrhythmias that can be fatal. And it's regardless, is a very dynamic field with possible therapeutic improvements. As to the RVC, it's a complex disease, as we said, with desmosomal gene or gap junction mutations. The diagnosis relies on structural, functional, electrophysiologic, of course, abnormalities, and the new treatment and the new diagnostic modalities, including mainly the MRI, along with the 4DCT and MDCT. Diagnosing that will depend heavily on the Task Force Criteria 2010, Task Force Criteria 2010, 2 major or 1 major, 2 minor or 4 minors, as I mentioned before. And of course, the genetic diagnosis is a strong pillar in this diagnosis, because it will make us confirm our workup and proceed to more steps to prevent sudden cardiac death. Thank you.
Thank you, Dr. Rami and Dr. Bashair, for this perfect, informative presentation. Really, we all enjoyed. And any questions? So one of the things I want to ask personally, we have all many patients of FOCAM. Usually what we are doing, we are bringing the families of the patient to do screening echoes.
Yes.
Like if they have kids 10 years old or older, we bring them to do the echo for all of the family members.
You're right.
Every 3 years. But what about the availability of this genetic testing in UAE here?
Okay. Would you like to talk about genetic testing?
Sure.
Yeah, fine, because...
So we've had some experience with genetic testing. Unfortunately, in the UAE, it's mostly covered only for Thiqa patients or local patients. So it's completely free of charge. Oh, sorry. Can you hear me better? Yeah. So it's completely free of charge for local patients as part of the Emirati Genome Project that started last year. And that includes a comprehensive 5,000, over 5,000 genes that include the majority of the cardiomyopathy genes. Now, for non-local patients, there are a couple of other vendors that perform genetic testing that might be at a lower price than the biogenics, which is what the Emirati Genome Project uses. I've not had personal experience with around 4,700 to 5,000 dirhams just for the blood test. But the dilemma there is when it comes back positive is those patients need to be plugged in with more genetic counseling and clinic as well. So there are some upstream costs too, apart from just the blood testing. I don't know if you have other experience.
No, that's about the blood genetic testing because Dr. Bashar was in contact with the lab
Dr. Azza
with
from
Dr. Azza,
Biogenics,
yeah, from Biogenics. As to that, as to the follow-up of patients with family history, I mean those patients, the families. I removed the slide because for time constraints, because I'm talking about all the other cardiomyopathies.
2-hour topic.
Yeah, it's a 2-hour topic. Mainly, if you'd like to know how to follow up these patients, I mean, the non-affected patients. Now, if you usually we screen direct first-degree relatives. We in the screening we'll do like ECG and echocardiogram. If we have any suspicion, we'll do a Holter monitor and or we'll proceed for a CMR. We're talking about hypertrophic cardiomyopathy. Okay, so we may repeat if things are fine. We'll be repeating that like in 3 years' time. That's what we used to do in the place where I trained in London. In 3 years' time, we may do it a second time. If with time, no symptoms, no. I mean, and if they're not carrying the gene that is involved in the primary pathology, they will be discharged from the clinic. If they're carrying the gene, so we'll be doing the checkup like once every 5 years if they keep on being asymptomatic. What's your experience, Dr. Mu'taz, on that? In terms of arrhythmias and stuff like that, how to follow them up?
I mean, from arrhythmia point of view, for the affected people, if they're not complaining of anything, they get just every 6 months or every 1 year, they get a Holter monitor.
Yeah.
If they're complaining symptoms, then we need to capture the symptoms. So
Yeah.
whether they will get a loop record, implantable loop record.
For asymptomatic, I mean.
So asymptomatic, they get once a year Holter monitor. For family members, I tend to screen them with echo and ECG. Initially the first time, and then every 2 to 3 years, I would repeat the screening for them.
So
if they had genetic testing, I will run the genetic testing on the family. If they're negative, they don't need further follow-up. If they're positive, then they will continue with serial echoes.
Exactly.
And
Once or twice after the genetic testing, and that's it, will be discharged from the clinic.
Thank you. The other, really, we appreciate that you highlight the role of CMR in diagnosis, because some uncommon forms of HCM, like I face a patient with hypertrophic cardiomyopathy, just he has concentric LVH, severe concentric LVH, and the gradient is not so much. So and he's hypertensive. So to differentiate, this is really the role of CMR. Yes. Thank you, doctor.
Thank you so much.
Now let's go again with beating heart. Again, Dr. Mu'taz, floor is yours.
Right, so for this one, you need to be really awake. This is going to be an interactive case. Unfortunately, we don't have voting system, so I'm going to rely on you raising your hands. There are no tricky questions here. It's basically a case. I'm going to take you through the journey of this patient and how I navigated the case and where we end up with, okay? So let's get started. So 81 years old female, non-ischemic cardiomyopathy, NYHA class 3, has been in AF for 18 months and was recently seen at a cardiology clinic, and Dr. Ahmed Munir said, I'm going to refer her to Dr. Mu'taz. Let him put a biventricular device into her. That will fix all of her problems. So on examination, her blood pressure is a little bit on the lower side. Her weight is 80 kilograms. Her pulse rate is 115 at resting ECG. Clear chest, but mildly elevated JVP and a bit of leg edema, well, significant leg edema to the knees. Her urea was 13, her creatinine is 129. On a lot of medications, but aldactone, digoxin, bisoprolol, Entresto, furosemide, and she's got some painkillers for her arthritis. This is her ECG. So shows atrial fibrillation, rapid ventricular rate, and left bundle branch block with a QRS duration of about 160 milliseconds. This is her echo. got a bit of MR there. So ejection fraction of about 15–20%, very severe left atrial dilatation, functional central MR, and there's evidence of, dyssynchrony as well on the echo. So when I saw this patient, you have to decide what you're going to do. What's your priorities in the treatment? And to me, there are three priorities. The first one is stroke prevention. The second one is heart failure treatment. The third one is AF treatment. Okay, so let's go through each one of them. So stroke prevention. She has a CHA2DS2-VASc score of 4 because she's a female, because of her age, and because of heart failure. Her risk of stroke is 4% annually. Her Hasbled score is 3, so she's a relatively high risk for bleeding as well. So we have to decide what we're going to give her for stroke prevention. So what would you do, what would you give her to reduce the risk of stroke? Would you give warfarin? Would you give a NOAC? Aspirin plus clopidogrel, left atrial appendage occlusion. So who would go for 1? Who would go for 2? Who would go for 3? Who would go for 4? Okay. So yeah, the majority got the correct answer, which is basically a NOAC. So let me talk you through that. So compared to antiplatelets, warfarin is better than antiplatelets. So if you look at the middle, the top, which is warfarin, is the middle. So compared to warfarin, aspirin is worse, clopidogrel monotherapy is worse, aspirin and clopidogrel is worse, warfarin and aspirin is worse. So there's nothing better than warfarin in terms of antiplatelets. But then we have the data from the NOACs trials, and it shows that in terms of stroke prevention, you have a 19% relative risk reduction with NOACs. So NOACs are better than warfarin, and warfarin is better than antiplatelets. So out of all of those, we go with the NOAC in preference to warfarin and in preference to antiplatelets. Now, left atrial appendage closure is currently, per guidelines, reserved for patients who are unable to take anticoagulation. So it's not normally a first choice or a lifestyle choice for patients who just don't want to take anticoagulants. In terms of risk of bleeding, again, NOACs are safer than warfarin. So which NOAC would you use? So dabigatran 110 twice daily, apixaban 5 milligrams twice daily, apixaban 2.5 milligrams twice daily, rivaroxaban 20 milligrams, or rivaroxaban 15 milligrams. So I know a lot of choices there. So who would go for option 1? Nobody likes dabigatran? Apixaban 5 milligrams twice daily. Apixaban 2.5 milligrams twice daily. Rivaroxaban 20. Rivaroxaban 15. Yeah, again, the majority got the correct answer. So there'll be many ways of doing this, but I'll take you through the reasons. So when I'm looking into this patient, there's 2 factors I'm thinking about: her renal function and her age. Okay. So let's talk about the renal function. So in terms of renal function, the dabigatran is not really preferred with patients who have a bit of renal impairment, just because it's predominantly renally excreted. So that takes it out of the equation. Okay. In terms of in terms of safety with renal patients, probably apixaban is the safest. Now, whether you would go with apixaban 5 or apixaban 2.5, she needs to hit the criteria for reduction of the dose, and she doesn't hit that criteria because her weight is 80 kilograms. Her weight is 80 kilograms, and her renal function is not bad enough to reduce the dose. So she goes on the 5 milligrams twice daily. In terms of the data for the people of above 75 years old, so in terms of the risk of major bleeding, apixaban is the safest out of all of them. Okay. In terms of risk of GI bleed as well, apixaban is safer than the others. In terms of risk into intracranial bleeds, all of them are quite good, probably apart from rivaroxaban. So based on all of that, for somebody at her age, apixaban is probably better than the others. Now, you tell me edoxaban, and you tell me, oh, I've got only rivaroxaban. I don't think it's a big deal, but when you have the choice, you have to pick one of them. And when you're picking one of them, that's the way I go through my head in terms of deciding which one I would use. So then heart failure treatment. Would you give this patient a biventricular device? Who would say yes? Would you give her a biventricular pacemaker or ICD? Yes or no? So who says yes? Who says no? There's some people who don't want to say yes or no. Yeah. Sorry? Yeah, so she's already on the list of medication she was already on these medications for 3 months. So yeah, you would probably give her. So a biventricular device is a device where we're trying to synchronize the right and left ventricles together so we can optimize the function of both of them. We have a lot of data for biventricular devices. So with CARE-HF, we can see that CRT therapy resulted in 36% reduction in mortality compared to medical therapy. In MADIT CRT, there's a 41% reduction compared to just ICD on its own. So there's a lot of benefit from CRT. And I remember when I went into clinical practice after I qualified, heart failure was a terrible diagnosis. It had a 50% mortality in 2 years' time. That was worse than many cancers. But at that time, it was just the beginning of the days of starting ACE inhibitors, and then beta blockers started. And you can see incrementally as we started, providing more of these, therapies, that our patients are now doing much better. So ACE inhibitors or ARBs lead to 30% reduction in terms of mortality. ACE inhibitors with beta blockers, you've reached 77%. If you added CRT to that, you've got a 90% reduction in the risk of mortality in 2 years' time. So who would benefit most from a CRT device? Well, females benefit most, left bundle branch blocks benefit most, and non-ischemic cardiomyopathies benefit most. So the favorable factors: left bundle, wider QRS duration, females, non-ischemic cardiomyopathy, patients in sinus rhythm, not patients in AF. And to achieve a good result with BiV pacing, your patient needs to BiV pace more than 95% of the time. So in her current state, would she benefit from a CRT? Yes or no? So who would say yes? Who would say no? Well, I'm coming to that. So I got you with this one. In her current state, she wouldn't benefit that much from the CRT. Because you see, I'll just explain to you why not. So the way the device works is that you have an atrial lead, which looks into when there's an atrial impulse or when it gives an atrial impulse. And the device uses that to decide when to deliver the pacing impulse for the ventricles, okay? So if you have either a native P wave or a paced P wave, it will say, after 150 milliseconds, I'm going to give an impulse to pace both ventricles. Now, if you're in AF, you don't have that reference point, and therefore the device does not know when to give this LV pacing. Coming to that. So in sinus rhythm, as I said, the device uses the P wave to time the onset of RV and LV pacing. And you will also choose the best AV delay to give you the optimal filling for the ventricle. So that's part of the benefit that we get with BiV devices. But in AF, the device will lose that reference point. So, and the rhythm is so irregular that the device does not know when to give the LV pacing. So you often get inefficient BiV pacing when you're in AF. And often you don't actually achieve that 95%. And we know that the responders, the people who respond to CRT pacing, are the people who BiV pace quite a lot. So if you have fully paced beats, the responders, 85, 86% of them, and even with fusion beats, so you're above 90% where you're pacing there and you benefit. But the non-responders don't have as much BiV pacing or true BiV pacing, what we say. So we know atrial fibrillation is not good for CRT, okay? For you to achieve something good, you need more than 95% BiV pacing. Often you don't achieve that with AF. Unless you have AF with very slow AV conduction and their ventricular rate is so slow, then you're okay. But in her case, her ventricular rate is very high, so she wouldn't benefit. So then what kind of device would you give her? Would you give her a biventricular pacemaker or a biventricular ICD? So who would give a biventricular pacemaker?
Sorry, Dr. Mu'taz, before jumping, maybe suggestion, yeah. Why we don't think about ablation, AV ablation in this patient? So we stop.
I'm coming to that, don't worry. It's along the way. So who would give a biventricular pacemaker and who would give a biventricular ICD? So who goes for a biventricular pacemaker? Who would go for a biventricular ICD? Yeah, see, if you notice, I didn't give an answer for that one because there's no right or wrong answer for that one. It depends on where you work. So in the UK, the practice is that if you're above 80, you probably get a biventricular pacemaker, partly for, cost effectiveness in the NHS, but also there's a logic behind that. So from a practical point of view, practically all the patients who qualify for a biventricular pacemaker would qualify for a biventricular ICD because their ejection fraction is low and therefore they will be good for an ICD. But the presence of advanced age and other morbidities may reduce the benefit that you get from the defibrillation side of things. The logic in the UK, for example, if you have somebody who's 85, who has tons of comorbidities, and you put a biventricular ICD, they're going to probably die in 2 years' time anyway, whatever you put in. Okay, you might give them better quality of life with biventricular pacing, but they're going to die of something else almost certainly. So the ICD benefit will become less. And this is, in this study, if you look at this, so this looked into the number of comorbidities the patients have. So on the first columns, they have very little comorbidities, and as the number of comorbidities goes up, you can see initially that there's not a lot of difference between the two groups, between ICD and no ICD, but then there's a lot of benefit, but then you reach the stage where you have a lot of comorbidities, and then the benefit reduces again. Okay, and that's because they have tons of, it's like having a really bad car and the windscreen wipers stop working, and you think, if I change those windscreen wipers, it's going to work fine. No, it's not going to work fine. It's still going to break down on the highway. So why we wouldn't consider ICD? Well, IC lead complications, you might end up with fractures in these leads, they're heavier leads, risk of infection is higher, inappropriate shocks from ICDs, the cost is higher, device longevity is often, well, maybe not these days, but traditionally it used to be shorter, and patients with multiple comorbidities. And sometimes, particularly in the UK, when we have the discussion with them, they tell you, I don't want to have shocks from a device, I'm happy with something that makes my quality of life better. So what I would always say, the decision to implant CRT or CRT-D requires discussion with the patient and coming up with the best plan. In this side of the world, pretty much everybody gets a CRT-D. So now we move to the AF treatment. So for this lady, rate control or rhythm control? So who goes for rate control? Who goes for rhythm control? Ahmad Munir raises his hand for both of them. So we know AF is bad for you. So if you look at mortality from the Framingham sort of cohort, you'll find that patients who have AF have higher mortality than patients who don't have AF. In the AFFIRM trial, however, when they compared rate and rhythm control, it says, oh, there's no difference between them, so we don't need to restore sinus rhythm. But one of the big exceptions is patients with heart failure. And there's trials that sort of started about 15 years ago, smaller numbers and gradually increasing, showing, okay, yeah, there's a bit of improvement in ejection fraction, there's a bit of improvement in reduction in hospitalization, but then we have the big trial, which is the Castle AF in 2018, which showed a 45% reduction in the composite endpoint of heart failure admissions and mortality. This was a landmark trial in terms of AF ablation for heart failure. So if you look at it, there's a very clear difference. And it's the reduction is in both endpoints. So it's a reduction in mortality, and it's driven also by a reduction in heart failure. So it wasn't just driven by one of those factors. Cabana trial, which wasn't necessarily looking into heart failure, subgroup analysis shows also patients with heart failure benefit from AF ablation. So being back into sinus rhythm is better for patients with heart failure. So how would you restore sinus rhythm in this patient? Would you do chemical cardioversion with vernicalin, chemical cardioversion with propafenone, DC cardioversion, IV amiodarone for 24 hours, then DC cardioversion, or amiodarone for 1 month, then DC cardioversion? So who goes for 1? Who goes for 2? Who goes for 3? Who goes for 4? Who goes for 5? Okay. I would go for 5. So chemical cardioversion count is not going to work in persistent AF. Chemical cardioversion with propafol, she has impaired LV function, you shouldn't use it. DC cardioversion, somebody's been in AF with dilated atrial like that without a medication on board is not going to work. IV amiodarone for 24 hours, you're not going to have enough amiodarone on board to keep her in sinus rhythm. So I would prime them with amiodarone for a month to make sure they had enough on board, and then I will do the cardioversion. That would give me the better chance of sustaining sinus rhythm. So now we did the ECG after the cardioversion. You can see she's got beautiful BiV pacing. Patient feels great. What are her chances of maintaining sinus rhythm at 3 years? Okay, 100%, 80%, 50%, 30%, or 0%? Who said 30%? That is the correct answer. See, that's because I sent you the slides before. So yeah, I mean, if you just do a cardioversion, the results in the long term are actually quite bad. You know, if you follow them up for 5 years, there's only about 10% of them that stay in sinus rhythm. Even after ablation, it's not that good. I mean, this is a study that we did when I was in Liverpool, and our 3-year success rate is roughly about 50%. But that's double the success rates of just cardioversion and medications. So 6 months later, unfortunately, despite my best attempts with medication, she goes back into AF. Patient doesn't want to have AF ablation or cardioversion. Her heart rate is about 105. Her BiV pacing now is 67% only. She has recurrence of her heart failure symptoms. This is her terrible ECG. Half of the beats are not being paced. She's getting ineffective pacing spikes happening in the middle of the QRS. They don't do anything. So what would you do next? Increase digoxin to 250, add ivabradine, increase the beta blocker, AV node ablation, or switch off BiV pacing. So who would go for 1? Who would go for 2? Who would go for 3? Who would go for 4? Who would go for 5? Good. So you're all going towards the right track. So yeah, I mean, you've tried medications, you've offered her ablation. She said, I don't want any of that. You want to achieve better BiV pacing. So AV node ablation. So the outcomes with AV node ablation after CRT and for patients in heart failure, it's actually quite good. And it's not a bad treatment when you give up on restoring sinus rhythm. So you can see overall they do better, their cardiac outcomes are better, and their heart failure admissions are significantly less. So in summary, adjust your anticoagulant therapy according to renal function. Heart failure and AF are common and they coexist in the same patient, and often they make each other worse. Tachycardia or AF-induced cardiomyopathy often improves with restoring sinus rhythm. CRT is not a very big fan of atrial fibrillation in general. And AF ablation offers better symptomatic and prognostic outcomes in patients with heart failure. It's gradually, with every adjustment of the guidelines, it's going up in the ranking. So it was 2B, now it's a 2A, and probably in a next update for the guidelines, it will become a class 1 indication in this case. Thank you very much. Any questions?
Thank you, Dr. Mu'taz, for your perfect presentation. Any questions? Yeah, there.
Just the concept why you use the oral amiodarone.
So oral amiodarone versus IV amiodarone for 24 hours. Yeah. So for you to really get a good antiarrhythmic effect from amiodarone, you really need to be properly loaded with amiodarone. What I always tell my patients, when you're giving amiodarone, it's like filling a barrel with water. you're not going to start seeing the effect until you fill up the whole barrel and it starts overflowing. And that's when you can start to see the antiarrhythmic effects from it. So for you to be properly loaded with amiodarone, you need about 10 grams of amiodarone on board. And that you would not be able to achieve it with 24 hours, where you typically give about a gram of IV amiodarone, okay? So your best chance in this case is to fill up the patient over a 1 month period with amiodarone until she has amiodarone on board, and then you do the cardioversion, and then your chances of keeping her in the sinus rhythm at that stage would be better. But then what you need to decide later on is what's going to be your long-term strategy. Are you going to just continue on medication, or are you going to offer her ablation?
Thank you.
You're welcome.
So I think Dr. Mu'taz, from start the patient to continue in sinus rhythm, it is very low incidence to be in, because she has low ejection fraction, left atrium is dilated. So from start, while putting the pacemaker and inserting the pacemaker, we can do after that in the same session AV ablation.
You can. So the data for ablation is better than the data with AV node ablation. So, you know, the data is now strongly in favor of ablation in patients with AF and heart failure. Now, half of this case is actually made up, okay? I've made up all the scenarios because I wanted to deliver certain teaching points about it. But, you know, you would be surprised. I mean, one of the last ablations I've done in Dubai, a patient, when we finished his ablation, he was in AF, his ejection fraction was about 15%. I thought he was not going to come off the ventilator, you know, because we did it on the GA. Like in 3-4 hours, his ejection fraction was 25-30%. Before he was discharged 2 days later, his EF was 50%, okay? So you would be surprised how quickly the ejection fraction goes down and how quickly it can go up with restoring sinus rhythm.
Thank you so much, Dr. Mu'taz. It's very, very, very nice presentation. Thank you very much.